discuss the use of a medial stabilized implant as a way to promote anterior stability, reducing the anterior translation of the tibia, posterior rollback, and rim contact, and show that it has higher function than an ACL and partial meniscal deficient designs. So the medial stabilized design can restore native ball and socket kinematics, which is based on the landmark work by Freeman and Pinskarova in 2004 when they looked at the movement of the normal tibial femoral joint. From 0 to 120 degrees, they stated the medial femoral condyle hardly moves. So in these projections from an MRI of a normal knee in full extension and full flexion, we can draw a line coincident to the medial plateau and draw a vertical line perpendicular to it and bisecting it. Then we best fit a circle to the medial femoral condyle and find its center in pink, and we do the same in deep flexion, and you can see that the relationship of the center of the circle is the same in full extension, full flexion, which means the tibia hardly translates anterior posterior on the femur, or there is negligible rollback of the femoral condyle on the tibia in the medial compartment. Of course, this is not how it takes place in terms of kinematics in the lateral side. We'll do the same schematic and place our perpendicular line that is perpendicular to the bisection of a line coincident to the lateral plateau. We'll best fit a circle, and you can see the relationship between its center and the vertical line. And now at 90 degrees, full flexion, you can see that there is a large amount of posterior rollback, and in fact the lateral meniscus has fallen off the back, which indicates that the lateral tibial plateau of the insert should probably be flat without a rim, and the medial compartment should be a ball and socket to restore the AP stability in the absence of the ACL. So let's look at this movie, and you can see that the AP stability, when there's compression, is provided by the socket medially. The flat lateral plateau promotes internal and external rotation, and the absence of a posterior rim decreases the risk of rim wear as well as instability, as the rim is not there's no rim to stabilize the knee. A kinematic evaluation of the GMK sphere implant during gait activities using dynamic fluoroscopy by Schutz confirmed this finding. So they're studying the MS medial stabilized GMK sphere, and it restored native medial AP stability and lateral IE rotation during gait, whereas the same implant company's ACL and partial meniscal deficient CR and PS inserts did not. So here are some top views of a tibial insert during level walking, downhill walking stair descent. You can see the AP position on the x-axis and lateral medial on the y-axis. And in level walking, the contact position in the GMK sphere medial stabilized was in the same position through the entire motion arc of gait. And the lateral compartment, you can see nice, relatively normal IE rotation, since there is no rim on the flat lateral portion of the tibial insert. So the first design feature for promoting stability and reducing the risk of late tibial component failure from posterior rim overload is a medial ball and socket insert to provide the anterior stability. So it comes in a CR posterior cruciate retaining and a CS posterior cruciate substituting. And when we look at the medial side, the CR insert slightly shallower than a true socket to reduce the risk of kinematic conflict with the retention of the PCL, and a bit more of a perfect one-to-one socket when the PCL is substituted by the concavity of the insert. The second design feature is the lateral flat and rimless insert, because it promotes native IE rotation during flexion. So if we look at the lateral MRI views from Pinskarova, we can see that we want this flat CR lateral unconstrained, which is the exact same shape for the CS as well. This reduces the risk, if not eliminating the risk, of rim wear, and may lower the risk of posterior wear as well. The third design feature to reduce the risk of rim wear is to have an anatomically designed base plate. that fully covers the posterior tibia, with an insert that fully covers the posterior base plate, and that when you best fit the anatomic base plate, it actually sets internal-external rotation of the tibial component and insert parallel to the flexion-extension plane of the knee. So here is a patient that has a sphere CS on one side, a sphere CR on the other. Notice they're kinematically aligned. The side-to-side alignments of the distal lateral femoral angle, proximal tibial angle, hip angle are the same. And if we look at the axial projection, we can draw a right angle connecting the center of the lugs on the femoral component for the sphere CS and sphere CR. We can then propagate that down and measure the rotation from those two lugs with respect to the tibial base plate, and you can see the angles are negligible in both. If we superimpose the anatomic base plate, you can see that the posterior lateral edge of the base plate covers the postlateral edge of the resection, and this sets the IE rotation of the anatomic base plate parallel to the flexion extension plane of the knee. And our design feature of trying to be sure that our plastic insert extends and covers as far posterior on the base plate, and the base plate covers as far posterior on the tibia, that this reduces the risk of posterior overload. Now, how good is this concept of a medial stabilized implant compared to a ACL partial meniscal deficient insert? We're indebted to this well-done single surgeon series by French and senior author Brighton, where they compared the outcomes of these two implant designs. This was a randomized trial, level 1. They aligned all components in both treatment groups with kinematic alignment principles. 50 patients received the ACL and partial meniscal deficient CR insert by Vanguard. 53 patients received a medial stabilized insert, the Safe knee, which was a predecessor to the GMK, with a PCL resection. At 1 year, the median score for the forgotten joint score was 80 points for those patients with an MS insert. This was 16 points higher than the ACL partial meniscal deficient Vanguard CR insert and comparable to a total hip